This is the lecture on an ankle foot orthotic prescription. So today what we're going to be discussing is application for an ankle foot orthosis to improve function, to describe some of the biomechanical methods employed in an AFO to achieve the orthotic goals, compare and contrast two different types of AFOs, and recommend and prescribe an AFO to meet the orthotic goals and to improve function. So some of the goals that AFOs provide is, as I play the video, we're going to watch the patient ambulating. And what AFOs can do that maybe your physical therapy intervention cannot is to help weight acceptance at initial contact. And so for initial contact, we really want that heel strike and that first rocker to start in order for gait to become more efficient. So for watching this patient ambulate, do we see weight acceptance at initial contact, but do we lack a heel strike? Is she able to clear her foot in swing phase? Or does it drag and maybe cause her to fall? Does she have good stability in stance phase? And what about her cadence and her stride length? Are they efficient for her? And what kind of excessive energy expenditure does this patient have, possibly due to any type of pathological gait she's exhibiting? So is she walking faster or slower than she should? Is she using extra energy with her lateral trunk lean? And what kind of AFO would help her decrease some of that extra energy she's having and give her more stability and stance? So one of the goals of the orthotics is to correct or accommodate. So down here, we see this patient has an equino varus, and so they're stuck up in plantar flexion. What kind of goal would the orthotic have to correct this? Would it help put the patient back with a flat foot? And as I play this video, think about what kind of goals that the orthosis would provide for a patient that has some of these gait deviations. Can it correct or accommodate things? Can it help reduce any pain? Or can it reduce maybe chronic pain in the future if this patient is having significant genu recurvatum? And think about what that would do to the knee joint over time. How could it improve stability during stance phase? Can it control emotion? So it can control the genu recurvatum happening during stance phase? Can it prevent a deformity? Can it assist in functional motion? And can it improve efficiency of the gait pattern? So improving efficiency, meaning will it help improve step length, stride length, velocity? And when we think about the goal of an orthotic, the intervention should try to provide the least amount of control necessary to achieve those goals. So when we think about the two patients that we just saw, we think about all the complexities in gait. So there was a lot of different dynamic or structural components with multiple planes of deviation in both the frontal, sagittal, and coronal planes. And some examples of this could be, for example, knee flexion contractures, femoral anteversion, or midfoot breaks. And what this does is that it causes patient frustration, non-compliance of wearing an orthotic, the intolerance of an orthotic, meaning it may cause increased pain when wearing or skin breakdown, and could also actually decrease function or mobility. So some of the biomechanical principles of orthotics is to provide function to an area of the body that is weakened or injured. So for example, if you look at this patient, he has a crouched gait pattern. And so he's got knee flexion, hip flexion, and ankle dorsiflexion. And so how can we provide an orthotic to that area that is not working correctly? How do we maintain this patient's range of motion that may be injured or weakened? Or, for example, for a patient with an equinal varus, how can we preserve the range of motion so this patient doesn't develop an ankle plantar flexion contracture? And how do we protect the areas for further deformities? So, for example, this patient has a genu recurvatum, and so how do we prevent further deformities that may arise secondary to spasticity or tone? So now we're going to compare and contrast two different types of AFOs. You previously had a whole lecture on the different types of AFOs, but we're going to differentiate between these two in order to prescribe one. So a solid AFO is either described as a solid or a rigid, and it provides this rigid support of the ankle in a desired position. So the trim lines come way anterior to the foot and they wrap around the front of the foot, and they have these straps to really control the ankle. So the solid AFO is used to increase knee flexion or extension by really restricting the ankle range of motion. It helps decrease an equinal varus and stance. It can possibly help with ankle control or some type of plantar flexion spasticity, and can help with overall balance. So some of the key considerations is the anterior trim lines really help produce this really rigid AFO. And you also are able to set this AFO into dorsiflexion if you need to. And if you set it in dorsiflexion, then this leads to knee flexion and stance. Or on the opposite side, if you put the AFO in a little bit of plantar flexion, what happens is that it can lead to a knee extension moment and stance and control for example, like a crouched gait. So now you have a ground reaction AFO, and this is a rigid brace that's designed to control knee movement or buckling. And if you see right here, it's got these anterior shells right here on both sides that really help with severe quad weakness, or it can help with a crouch gait pattern. So it really helps in the stance phase to control for knee flexion. It can help increase gait speed if we add a soft heel or a rocker sole to the shoe, and helps with balance. So looking forward, when we're thinking about picking a design of an AFO, what we want to think about, we choose one for potential improvement. So for example, this patient is ambulating and they already have their AFO on. So if we can hypothesize what kind of AFO they have and what it can be controlled for, we can tell that she still has a little bit of in-toeing. We can tell she has a little bit of a lateral trunk lean. So we can gather she probably has some type of spasticity. We can gather that she may have some contractures. She may have some pain. And now when we watch her walk without her AFO on, we can see that she does have an equinal varus contracture, and that the AFO is really being used to help her in both swing and in stance phase, and is helping her with her efficiency and gait, as she is got now decreased velocity when she's walking without the AFO on. So as we watch the last slide, we're going to try to recommend and prescribe an AFO for a patient. So we're going to identify some gait deviations. So first we're going to look at if they use an assisted device and what type of gait pattern. We're going to look at the spatiotemporal pattern, so gait speed, cadence, step length. And then we're going to look at the gait deviations and think about how they accept their weight, if they can perform single leg stance and clear. And we're also going to analyze the functional significance of this and hypothesize what we would like to prescribe. So as we watch this patient ambulate, we're going to document that he ambulates without an assistive device, that he walks pretty much with a step-through gait pattern, and that he walks with a slightly slower velocity. So those are the spatiotemporal. And now we're going to look at some of the gait deviations. And so in swing phase, he's got decreased clearance and swing. Swing phase, he has a circumduction gait pattern. And then in stance phase, he doesn't have heel strike at initial contact. His foot lands in foot flat. So he doesn't have that rocker to produce an efficient gait pattern.